you all for joining on behalf of Dr. Nita Ahuja, our Interim Cancer Center Director at the Yale Cancer Center. Dr. David Fisher, want to invite everyone to sit back and enjoy this. It's going to be a wonderful presentation by Dr. Jessica Dudley. But before we get to Dr. Dudley, wanted to talk about the Iris Fisher Lectureship, which was endowed in 1999. And since then, we've been very fortunate to have some pretty amazing speakers. I think last year was Dr. Ethan Bausch, from what I remember. Dr. Fisher has over a 60-year history with Yale School of Medicine. He was and is the first medical oncologist for the New Haven community. He was in private practice, but then came over full-time faculty in 1995. Obviously, he's had countless contributions to the Yale School of Medicine, the Yale Cancer Center, the Smilow Cancer Hospital, and our community. But really important for today is Dr. Fisher's wife, Iris, was diagnosed with sarcoidosis, an incurable disease, and really a lot of the decision-making in terms of what types of treatment and quality of life in terms of her personal well-being are really immortalized in this lectureship. So, it's really phenomenal that we get to do this every year and bring fantastic faculty and people around the country and around the world to be able to present. We of course wish that Dr. Jessica Dudley was here in person, but maybe we'll get a rain check or invite her in the next couple of months if things clear up a little bit more. Moving on to Dr. Jessica Dudley, she's the Chief Clinical Officer for Press Ganey, and this is what the focus of her talk is going to be on. But really, I want to take a few moments just to talk about my personal relationship with Dr. Dudley. She was my chief medical officer when I was on faculty at Brigham Women's Hospital and the Brigham Women's Physician Organization, and really, looked up to her as my mentor. She really helped me navigate many crises, whether it was in the care of our patients in my area, specifically in breast cancer patients, and really even personally through some of the things that I had to go through. And a huge loss for the Brigham, a real amazing gain for Press Ganey, and it's absolutely phenomenal that that she's here with us today. I did want to share one quick picture because I'm not dressed up, but this was my 2010 Clinical Collaboration Award that I won from, was awarded by the Brigham Women's Physician Organization. I had a little bit more hair there. Dr. Dudley has not changed a bit. And with that, I'd like to pass on the floor to Jessica. Thank you so much for being here.
Oh, Mara, thank you so much, and for making me laugh with that photo. Not because you're in it, I'm very proud of you, but because I was thinking about when I took the job at the Brigham. Hold on, I'm just trying to get to my slides. When I took the chief medical officer job at the Brigham, in my job description actually was hosting that gala. And I thought, I had this big population health background and was very focused on care innovation. And then the gala, which was a wonderful event to celebrate all of our physicians. But having to pick out a dress to go to the gala, you just brought back a lot of stress. But it's all good. It's all behind me now. Great. So first of all, I'm so honored to be here to speak with all of you today. And thank you, Dr. Fisher, for this incredible honor to be presenting at this specific grand rounds, and Mira and all for inviting me here. I am really excited to spend this time with all of you, and I have quite a few slides, and my goal is not to kind of bury you in these slides. My goal is to hopefully engage you in thinking about these issues, and I think things that you've probably, I know, think about quite a bit, but hoping that by the end of this, maybe I can shine a different light on it and share a little bit of a different perspective, and one that hopefully going forward, we can work with each other and continue to grow.
Just switch it, sorry, to present you're showing like the next slide.
Okay, so let me work on that because I was worried about this and I'm trying to get it in. Sorry.
No,
It's supposed to be in the slideshow mode, but it sounds like it's not.
not yet.
Hold on one second. Give me a
Sorry
second.
about that.
Give me 1 second. Stop share. I want to share and I want to share this screen. And I have that sound on. Share screen. And then this should plop it into. Is it still, are you still getting my notes page?
Oh, got it. You're great.
Okay, let me know if they pop up because I'll just kill it if that happens.
Seems fine.
Okay, great. Okay, let's get going. So I called this two sides of the same coin, patient experience and clinician engagement. And I came to Press Ganey, as Mira was saying, 2 years ago. And I don't think I really understood then what I do understand now, which is it really is two sides of the same coin, meaning, and I can like feel that, but I'm going to show you data to hopefully convince you of that. I'll also add my bias, which is the coin does not exist without the foundation of a really engaged clinical workforce. And that also means that the clinicians have to be able to do their jobs well and have to be well. So we'll go through that. I know that all of you are still addressing the challenges of COVID, and I suspect that's going to be with us for a while. And I'm going to share with you our data for both patients and the workforce regarding COVID. But then I really want to spend time showing you things that organizations are doing to solve for a lot of the challenges that have appeared, and hopefully give you some ideas and maybe think a little bit more about how you're solving these challenges. Because I know, having talked to Dr. Sampt, and I work closely also with Dr. Bennett, that you're already pretty much on your way to addressing a lot of these issues and have been for a long time. So some of you may have seen this slide, maybe not, but this is really the perspective that Press Ganey has when we use the term patient experience. A lot of people say patient satisfaction, but we're really focused on calling it the full experience and making sure when we're using that language, we are absolutely talking about quality, safety, clinical excellence. And then we know none of this happens without the foundation of the care team. And it's a team. And I know you all in cancer care know that probably better than anybody else in medicine. And then the other point is, while we often capture data in specific settings, we know patients are getting their experience across the continuum, often when they're not even actually directly getting care. So I just want to put that definition out there. I also know that we all have our own story, even as clinicians, of being patients and experience care often in our own systems. And, I think all of us as caregivers kind of often cross our fingers and just like hope it goes okay, because sometimes we know how many things have to go right for it to go well. And this was just an experience I had over the summer. My husband finally was able to get an elective surgery completed in June. And we actually did it at one of our organizations where I practiced. And I'm going to say overall, everything went very well. So we got in there. The nurse, after the doctor checked us in, said, the doctor forgot to mark which side of your body we're going to do this procedure on. She needs to come back and do it. I'm paging her now. And I was like so relieved as a patient, that as the family member, that happened. And there was no hesitation from the nurse. And I thought, that's so awesome. They have their safety culture down. And then an anesthesiologist came by and he said, hi, I'm Josh. I'm your lead anesthesiologist. I have these 4 other people. He introduced all their names and talked through what everybody was going to do. So I had another kind of, okay, great. Like, they have team culture. This is all good. And then he got through a surgery and we were in the PACU, and this nurse was just all over it. My husband was totally out of it. So I came in there and she was just explaining everything to me in a very kind of incredibly constructive, detailed way, which is exactly what I needed. And I said, wow, this is, you're so helpful. Thank you so much. You've been doing this for a long time. And she said, well, I've been here for 20 years, but I've only been in the PACU for 9 months. And I said, well, what happened? She said, well, COVID happened. And after 9 months or so of COVID in this unit, after I've been here for 20 years, I just couldn't do this anymore. And in fact, all of my colleagues have left. There's only 3 of the senior nurses remaining. And I was going to leave altogether. She said, but then I remembered when I first came here 20 years ago, they said to me, nurses are like potted plants. They come, they stay, they never leave. And that was not how I was feeling at that moment. But I was able to get some support and engage with my colleagues. The hospital sponsored some very informal peer groups. And that helped me realize I did want to stay. And I'm actually thrilled to be working down here. I needed a change of scenery, but I'm still here. So I just wanted all of you to know that I know for many, this has been like an incredibly challenging time on top of, an incredibly challenging, probably decades of careers for many. And I'm worried because I don't want folks to leave. And I loved the image of that potted plant, and I just wanted to share that. So I'm going to share some patient experience findings, and then I will go ahead and share some workforce findings, and then we'll talk about solutions. So most of you probably, that Press Ganey has a lot of data, and I'm going to briefly flip up a slide to show you that, so you can believe me when I tell you we do, but I don't want to make it painful for you to have to sort through all the data. When we look at our kind of hundreds of thousands and millions of comments from patients, and we look at them across all settings, inpatient, ambulatory, emergency medicine, and then all different outpatient sites, ultimately, there are a few big themes that really shine through, and I put them on this slide. And they're very similar to what I felt with my husband in the story I just told you. The first is about keeping me safe. So marking that side of the face, knowing that, balls aren't going to be dropped. That's really critical, of course. The working together is, of course, the most important because this is a team sport. And then the caring piece. And I know you all have worked really hard, I think, across your system on the caring, on communicating the caring piece, which is a huge component of that. But that all doesn't happen unless we have this engaged workforce. This is the data that we're going to skip, so you don't have to try to figure out the slide. But I have one for inpatient, ambulatory, emergency medicine. It has gone through it all, and those, trust me, that in that purple box are those 3 themes of keep me safe, work together, and care for me. They look slightly different because in the inpatient setting, it's, the room clean is the measure of safety in that setting. But trust me, these themes are the same and across all of the settings. So this is now data you may not have seen because this is some newer data from COVID. And we recently acquired a company that's able to take unstructured data, so comments that people put into surveys, that patients put into surveys, and then organize that. So instead of just anecdotally remembering the last thing that somebody said or trying to sift through these, literally hundreds of thousands, or in this case, 18 million comments that were collected, we can actually now, using this kind of patented technology, extract the real themes. And this is just to show you that these themes of gratitude, of kindness, of empathy, they are shining through in this COVID time more than we've ever seen before. This is from our national data. We do have your data, so Yale's data, and this is just a kind of graphic way of grouping the comments. So when we look at your positive comments from this past year, these are the main themes. So this kind of courtesy, respect, kindness, the size of the box represents the N of the comments, the proportionality of them. And that is what patients take the time to write in about. Yes, of course, skills and knowledge are important. And yes, of course, some of the logistics, but the big bulk of the positive feedback is in the space of the caring, courtesy, and respect. And those are just a few quotes that you can read there. You know, Dr. X is the kindest, most courteous and knowledgeable physician, kind and knowledgeable, etc. So of course, we want to hear it all. And these are the negative comments. And honestly, and I've seen your data too, the positive comments are almost always more than the negative comments, like the volume of them. We tend to focus on the negative, can't help ourselves with that, but trust me, the positives are outweighing the negatives. When we look at the negative comments though, you know, they're slightly different and they're very, very focused on what I'm going to call logistics. And reliability and scheduling is that biggest block here. And we have seen this a lot in COVID, and we know how hard it was for everybody to change, innovate, and deliver care in a very different way. I'll tell you one place where we've really seen challenges around logistics was initially in the telemedicine space, which patients actually loved and had a ton of positive comments about connecting with providers and feeling so grateful that that was able to happen, but a lot of frustration with using the technology. And that comes up in this, you know, very inefficient as far as managing time for patients, and then these delays down there. And I meant to tell you, please, if you want, put questions in the chat and I'll try to respond to them as we go. Okay, so this is also a newer slide you probably haven't seen, and it's a little bit complicated. It's how we group our data and flow it, but this is your data, by the way. This is YALE'S data. So this is really trying to demonstrate that even when you have patients who are very loyal, so that blue ball on the left says that you've got, of the 30,000 patients that were included in this particular measurement, that 87.1% of them, which is benchmark at the 76th percentile, this is the cohort that says, you know, I'm going to score this the highest possible. I'm that loyal to this organization, and that's I'm giving it the highest possible or top box score. What happens though, and what we've been looking at now, is that when patients have friction points, so hassle experiences before their visit, that actually greatly impacts what happens to their kind of likelihood to recommend or loyalty to the practice. So in this example, a little more than half, they didn't have the friction, and I'll tell you what those points are in a minute, and their scores went up even higher. So even more likely to recommend 99th percentile. But a little less than half did have some friction, and their scores go down. So they then score you at this 73.2, the 9th percentile. So that's for friction points that happen before my visit. Those are things like courtesy of registration staff, ease of contacting, ease of scheduling the appointment, providing information about delays and wait time at clinic. Those are all the components that make up this before friction points. And then the care happens, and there's another kind of logistics piece that happens or can create friction during the care. And again, all of this is outside of the experience with the care provider. And this is cleanliness of the room is one of the examples in this space. So when that doesn't score, when that is not kind of up to snuff per the patient, the score drops even further. So you go down to this 34.3 or the 1st percentile. It's forgiving though, patients are forgiving. So even if you have all those friction points before the visit, but then you deliver on the cleanliness of the room, you kind of come back up here to this 88.4, 84th percentile. Hopefully you all followed me on this, with the take home message being like, these friction points, these hassles really impact overall experience and how patients rate their experience. I know no surprise to you all, and I also know that hassles are impacting all of you, but I think it's really important that we've now can show this with the data, because it enables practices or units to really focus now on these areas that otherwise might have gotten kind of wrapped up and bucketed it, and we wouldn't have that level of detail. Okay, so I'm going to shift to clinician specific findings. So just like we have a lot of data on patients, we actually have a tremendous amount of data on clinicians. And honestly, I didn't even realize this when I came to Press Ganey. I knew that we had a good amount of data on the workforce. Like I know that Press Ganey would survey our employees, but I didn't realize that we have the largest clinician database in the country also. So we are surveying approximately 125,000 physicians annually and about 50,000 advanced practice providers. So it's a very big data set. So we're also now able to kind of look and dive deep into that data set to see, at least at the aggregate levels, what's most important to physicians and what's most important to APPs. And so we did that by looking at one of our survey driver questions, which is intent to stay for 3 years. So we asked that question. And when we asked that of our physicians, these three themes kind of surfaced to the top. So the first for physicians is about kind of certainty and success of the organization. And this is what kind of makes them feel most confident and about and this is the #1 key driver for actually both male and female physicians, is the certainty of the organization's success. So the second key driver, it's again the same for male and female physicians, is work-life balance. And this is literally that this location supports me in balancing my work life and my personal life. And I think this is really about the importance to all of us that we are in this profession and want to be in it, but it has to kind of be a part of our lives because we all have lives outside of it. And if our organization can't help deliver that, that makes it really difficult for us to want to stay. And then the third one, which is, again, this creates this link, and not surprising, I'm sure, to anybody here, is that the location provides high quality patient care and service. That is an absolute driver. Like, we need to know that if we're going to stay at our organizations. So for APPs, it's similar, but a little bit different. And these are the themes, and I think that that's probably a good way of thinking about APPs in our data in general. And I actually often feel like APPs is kind of the lost cohort because they spend a lot of time. I think our APPs spend a ton of time with physicians, but they're not always measured with them. And there are some differences, and they're not really fitting in with any other. So we've been really active at looking at them both separately and then aggregating their data into this clinician space. But for APPs, and again, we've looked at it for male and female APPs separately, but these are the big four themes that we find for their kind of interest and intent to stay for a 3-year period. So the first is this: I feel like I belong in this organization. That's the #1 key driver for male and female APPs. I like the work that I do. Then we have the patient quality and service that had also, we just saw with the physicians. And then another interesting driver here is this respect and confidence in our leader, both the direct person I'm reporting to and then senior management overall. And that's become, I think that's a really interesting insight into thinking about kind of where many of our APPs are connecting and what is going to be really important to keep them. Okay. And I will answer questions. So the great question. So if I've showed you any like Yale, any data right now, it's Yale New Haven Health overall. I do have, and I can send it to Tara, the Smilo specific data. So I had that. I have like a Smilo specific breakout for those, that circle picture with the hassle factors drivers. It actually looks quite similar to Yale New Haven, but better in certain areas and maybe a little bit different in a couple of others. And I will make that point about the data in general. To actually like make change happen, all of us need to look at that data at the practice level in order, I think, to really ultimately understand what's driving, what the drivers are for each practice. Okay. So this is everybody's moment for interaction. So if you could take a second and look at this picture and tell me where you think you are, and if you like, you can say like, this is where I think I am, or you could say, well, this is where my colleagues are. But this is this phases of disaster slide. Some of you may have seen this before. I used this early on in the pandemic. It's not COVID related at all. It's kind of used for national disasters or other instances, and it's on the kind of SAMHSA mental health support site. So what it shows is, and I'm waiting for anybody who's ready to type, who's already ahead of me, but what it shows is as an event unfolds, there's this kind of anticipation, and we saw this across the country, by the way. We formed a caregiver collaborative right when COVID started last March, and we included lots of folks from New York, Connecticut, New Jersey, who got hit hard fast, and the rest of the country was kind of sitting and waiting. So we actually lived through this, and then there was the heroic and the honeymoon period where lots of support and cheering, and people felt like, okay, we got this, and we have treatments now, and then we got a vaccine, and we can do this, and then this kind of disillusionment phase. So I'm looking here, and I see a lot of people saying like 5, well, not a lot of people, but I see 5 from most people, and some people are saying 6. And I'll tell you, I've also showed this slide with a lot of folks, and there's been a lot of 4s. I showed it a couple weeks ago, and I got the feedback that my slide is wrong, and that I need to fix it and make it this kind of downward sloping bucket needs to happen again and again and again, because that's how they are feeling right now. But I will say most leaders feel like they're somewhere between 5 and 6 and that they can see a light. Okay. So we have colleagues at Press Ganey who actually lead a lot of our safety work. And I think some of them have worked with you guys over the years, our HPI safety consulting group. And a number of them have military experience, and they spent a couple months kind of looking at our data, talking to folks around the country, and really landed on why they think healthcare workforce experience during COVID is actually been far more difficult than experiences in the military. And for these 4 reasons, and the kind of relentlessness of the experience that you can't go home, especially early on, and get away from it because there was so much concern about safety and exposing families. For women or for men who are the kind of principal caregiver for their, if they have kids or parents that they're caring for, that going to work and coming home was around the clock the entire time, and really felt relentless. And then what we're seeing a lot more is this oppositional piece that I think is driving a lot of compassion fatigue and secondary trauma for many folks right now. So this is, I don't think anybody's seen this. You might have seen it. It was tweeted a couple weeks ago, but it's not yet published. This is from this EPIC research data of like 350 organizations that are using EPIC. And they were just tracking the % difference in digital messages that are coming from patients directly to providers right now, to physicians. And there's been 157% increase in that volume of digital messaging. Now, it's not an absolute, so you could have had 4 messages a day before, and now you have 7 messages. But it's a huge shift. And the glass half full piece of this is like fantastic. Patients have finally figured out how to use the portal. That's great. The glass half empty is, oh my goodness, we built it, they came, but we didn't actually figure out how to manage it. So it's this overwhelming amount. And this is when I talk to my colleagues in primary care, they are overwhelmed by this amount of messaging and lack. They haven't had a chance to build the system to manage this influx appropriately. So I wanted to share with you just a couple of the terms that we use a lot. One is resilience, and this is really this ability to recover or adjust when challenging things happen. And we measure resilience with 2 different sets of metrics. One is about activation, and it's the ability to kind of get charged up, ready to go, and find meaning in every encounter. And then the other is to decompress, to be able to go home, recharge, and recover. And we absolutely need to do both if we want to remain resilient. So I'm sorry for the like small font on this, but I do want to point out, and I'm going to talk about engagement in a minute, that physicians of all the professions in the hospital score the lowest for both resilience and engagement. We'll talk about engagement in a minute. And for resilience, so this is physicians down here. This score, the overall score, is made up of 2 components. Activation, physicians are great at getting activated and treating each patient as individuals and finding meaning. And where physicians really are struggling is their ability to decompress, to be able to go home and disconnect from work communications, to be able to sleep, recover, and be able to come back the next day. And this is what we're going to talk about. I will make one, I've seen the resilience data for this past year. And the one flip that I thought was interesting is teaching faculty have now dropped below physicians. Their resilience is lower. Again, due to decompression. So now, as tough as this is, we are seeing places where there are some kind of hopes and bright spots. And I'm going to call this one of them. So this is looking at engagement. So engagement is how we measure. We have a set of 6 questions that we use to measure kind of an individual's likelihood to go above and beyond with the organization that they're working in. We capture things like pride and likelihood to recommend the organization and send family there. And so as you can see from this, over the past couple of years, although there is a cohort that's having a dip down in engagement, and we are seeing this from many, that the engagement scores are going down. There is a group of organizations where physician engagement is actually going up during the pandemic. And I like to think that's because of, honestly, the concept of high reliability and leadership stopping and recognizing that they might not have the answers for many things, but those on the front lines probably do. And actually creating the space to listen and take that information and act on that. And we've seen all across, and I actually seen, because Michael shared with me the depth and breadth of the communication approaches you all had throughout your pandemic, where your frontline voices were heard and actually, I think, greatly informed decisions that were made. And that's something that we don't often see when like times are normal in healthcare. So we now need to I'm going to focus on how do we move forward and address these challenges. So I do think these are 4 major challenges facing most organizations right now. And we'll go through them. They're actually pretty connected, because when I use the term well-being, it's far more than my individual well-being. It's thinking about the organizational kind of well-being as well. But I suspect that these issues of trust, uncertainty, and staffing are ones that you're all challenged by. I will say that, and I'll get to this later, that the accountability for addressing and solving these challenges can't just happen at an individual level or at an organizational level. It's got to happen also at a leader level and at a team level. these problems are too complex. And for some of them, like getting, like I talked about earlier, to the unit of measurement that's most important, and that might be your practice in your clinic, is going to be really critical if we're going to solve these problems. So I'm going to talk a little bit about well-being. And these first 3 slides are a case study from an organization that decided they wanted to really go deeper to understand what was driving 4 things they were very worried about. That was resilience, both activation and decompression. And this was for their clinicians, their APPs and physicians. They were also very focused on productivity and on intent to stay, because they really don't want to lose a single physician or APP, given the challenges right now. So they've had a very kind of robust look at this. They did kind of what many people do as the engagement survey, but then they've dug deeper, and they've dug deeper into the data, and they've dug deeper into listening to their front lines. And then they've used this information to help prioritize and begin to build their roadmap going forward. So this is just a schematic for the data, and I don't want to get lost in this, because trust me, it's a lot of detail. But basically, we are taking survey data, we are taking your EHR utilization data, so the minutes that people are in it, and the time of day that they're in it. We're also looking at productivity data from your human resources platform, and we can integrate all of that together and then surface what are the key drivers for these areas that we're very focused on addressing. And this is, again, a schematic that's just trying to show you it is not going to be one thing that pops out. And most things fall, I think, into these 3 big areas. What we can learn by going deep here, though, is the actual impact and what will happen, the likelihood of something happening if we go to fix it. So, for example, for this group, it became very clear that a huge driver of the challenges for doctors to decompress was around the EMR efficiency and proficiency, and the challenges of resources and workflow in the clinic. And this came out when we looked at their decompression data and saw that, like, those people who were doing really well versus those who weren't, it was due to things like the amount of time that they were spending charting, or how many days until their next appointment was available. And those who were kind of swamped were doing far worse than those who weren't. So again, things that you would think, okay, I get it, but the fact that the data revealed it then gave them something to kind of stand on to try to then help address what the challenges are. Lots of other areas, and I think these are probably ones you're well aware of, which is the role of leadership in addressing kind of culture. And then what do we do to better support individuals and teams? And actually some of those themes came up when we were looking at the earlier data. So I was going to show this video, but I'm a little worried I'm going to run out of time. So I'm not going to show it, even though I think it's really powerful, and I will send it and anybody can watch it. It's a really wonderful 3-minute heartfelt video. And I'm using it as an example of how important it is, and I know you know this, to feed back these comments from patients, the positive ones, so your providers can hear them and remember just how important they are and the work that they're doing, how much they are changing people's lives. And this is not just physicians, it's transport folks, it's the helicopter EMTs, and they're all reading letters of patients that were written to them specifically. And they're all kind of recognizing, gosh, I didn't realize I needed this, thank you, but I did, and it really makes a difference. There are a couple other areas in well-being that we're seeing folks do. And again, I suspect you're doing some of this here. I would say the concept of peer support has kind of never been more important. And it can be like simple or it can be very complex. And we are seeing organizations do all variations of this. The kind of themes of what happens with peer support and why it's so important are what I wanted folks to just focus on for a minute. But it for sure is true that, well, one, we as colleagues know each other and might pick up and sense things that you know, somebody that you don't know wouldn't necessarily pick up on. We also, unfortunately, there is still often a stigma around getting help. And this is something that, you know, we all have to work more aggressively to fix that stigma around the need for emotional support. And there's been, I'm really hopeful right now that we are going to change the paradigm around that. And that's something that I'm working really hard for us to focus on and address that. We have to make it easy for folks to access mental health and meet them wherever they're at. And that's what these 3 examples that I threw up here show. This first one, which may be hard to see, this resilience check-in list, this was created by an organization, actually Valley Health System in New Jersey. They copycatted from an organization in the Pacific Northwest, Intermountain, and Intermountain did it as a going home checklist. Valley Health did it as a coming in checklist. But the goal was, we need to remind our colleagues that we are here for them, that they need to check in and make sure they're okay, and that there are resources to support them, and we'll meet them where they're at. You know, Columbia has a very comprehensive program. I suspect you all have a pretty comprehensive program for accessing mental health when folks really need professional support. And then the bottom one is an example from New York City Health and Hospitals that have really built a kind of pyramid type model to try to capture for their entire workforce those who need support and create a buddy system and then really work their way up. The pointy part of that is the seeking help from a professional. Coaching is another area that we are seeing folks kind of lean into more actively than before. And I think part of that is this recognition that, wow, you can do this virtually and it works really well. Some organizations are building that, others are outsourcing it. If you build it internal, you have this like win-win opportunity, because most folks who take the time and coach also get a benefit, as well as the person being coached. Trust after well-being was another area, and it's something that we're all working really hard. And I know it's, again, you all have, you know, maybe have trained up more folks in communication than any other organization, at least that I am aware of. And I think like keeping that dial turned up is going to be really important on this. This is really talking about communicating and connecting with the workforce. So it's so critical. Of course, we do that for patients, but it's really critical we do it right now for the workforce. So this is rounding reliably. So not just ×1, and there's no way like a senior level leader could round on every unit or department. I mean, they can and they do, and we see folks around the country doing that. It will take them a year, right, to get to everybody. So this is where, again, this rounding has to happen at a very like small team level, so that that leader is present and hears from their team how they're doing, how they're not doing. We have seen this for nurses, physicians, APPs, and just like showing that you are present, that you care, that you're listening, that you are transparently communicating back what you can fix and what you can't, has really gone a long way for folks. And something that, you know, the trick with this is to do it reliably, meaning the same on a consistent way over time, not just ×1 or once a month. I suspect all of you are pretty familiar with, well, actually, I don't know, because I have a mix when I tell people about this concept of psychological safety. I know Mira is, because we took a course together, and Amy Edmondson is one of the folks who really talks about this a lot, using examples from all sorts of other industries, especially spaceflight. But she's also really done a lot of her work in hospitals. In fact, that's where she started. And this concept, this is a picture of Gramercy Tavern in New York, because even in a restaurant where you think the stakes might not be so high, although this is a pretty expensive restaurant, so the stakes are pretty high to get it right. The expectation is that the wait staff on their first shift on will ask for help at least 10 times. And they are encouraged to do that. So their leaders, their kind of team lead, models that it is okay for them to ask for help. In fact, they expect them to do it. So they're framing this in that way. They, the leaders, demonstrate that they are far from perfect. And then they thank people when they ask for help. So this kind of psychological safety concept, this set of tools are things that we need to train our leaders in. And we, the clinicians on this call, you are leaders, whether you may have a leadership title or not, for sure, whatever practice you're in, I'm sure you are perceived as the leader. So knowing how to have the skills to help other people speak up and engage them and support them is really critical. This is from an organization that actually is one of our top performers. It's a large system, and they have been on a journey, just like you, just like many organizations have, for many years to improve both patient experience, and then in the last 3 or 4 years, very focused on their workforce, specifically their clinicians and APPs. But when they started their journey back in 2012, they'd been very disparate. They came together and they were very focused on how do we become a system? How do we create that communication? How do we create some bit of sameness, but also permit some local autonomy? They ultimately embraced high reliability as their kind of building block foundation for doing this work. They have been rigorous about measurement. And then in the last few years, their kind of solve for the clinician well-being challenges has been both a fix the system and then assist the clinician approach. But I did want to just spend a second on high reliability. I know you have a framework here. You use the CHAMP acronym. I actually asked Michael about this because I talked to Press Ganey colleagues who had years ago worked with folks, and we used this acronym, and Michael whipped out a card and showed me that indeed you do have this. And I think this is a very helpful way of remembering those high reliability behaviors that are so important if we want to deliver care to every single patient and get it right every single time. And so these communications, all of the things that I know all of you work to practice, work to do already, how do we kind of hardwire that in so that we do it not just with patients, but even as we're working to support our workforce, even as we're working to find ways to be more efficient and to deliver care that is of the highest quality. So this is the performance of that system, and they really are super performers. So these are the highest percentiles that we have for employee experience, this rising tide of physician engagement, and then patient experience. So I'm actually so for staffing, I'm going to mention just very briefly, there is no silver bullet, just like there is no silver bullet with any of these things. We work with organizations, many of them, everybody is struggling right now with staffing, and it's mostly nursing or like technical support in like respiratory therapy or other kind of skilled positions where folks are choosing to leave and do something else or dramatically cut back their hours or go and do the same thing, but in a site of care that's easier than the rigors that they're experiencing where they're currently working. So the solve for this, honestly, are the same concept of high reliability, really taking the time to communicate. So one of our Western California-based health systems have set up ways of communicating and listening to nurses beyond the rounding. They are surveying them actually every quarter to make sure they get their voices heard, and then they are responding immediately. And again, it's with this communication, even if we can't solve exactly what you're asking for, here's what we're doing and why. For most places, figuring out how to what's called force multiply. So that really is this concept of practicing at the top of your license. So how can we take the stuff off of the physician, PA, nurse's plate that they don't have to be doing and support them with another set of resources. So in some places, folks that had stopped using LPNs are pulling LPNs back in to provide that type of support. Figuring out how to change the inbox messaging system, so all of those messages aren't going directly to the provider, are examples of this. I'm seeing some of the questions in the chat. So one of them is about how do we get leadership to respond to concerns with action, which I think is a really great question. So we're going to get to that in a minute. And I'm going to get to that actually after my next slide. So we've covered a lot, and I think it's really important to remember the connection between working to support our clinicians and the work you're already doing to take care of patients. I'm going to start with this concept of removing the hassles, because we know that's what's making it so challenging for folks to decompress. The patient quality and service, that's the kind of sweet spot for all of us. And then really focusing on trust and belonging, and that includes the psychological safety that we were talking about. This is what's going to propel us forward and kind of enable us to be successful. Using high reliability concepts really for every single thing, whether it's safety, whether it's engagement of our people, whether it's looking at resources, being able to deliver these types of aspirations reliably every time, so that every individual, whether it's a patient or a caregiver, are having these experiences, is really what we need to hardwire. And then to answer the question in the chat, this is how I think we need to change our thinking on this. So instead of thinking of solutions that belong, and this is something I mentioned earlier, either to an individual, like go get, yes, Jessica, if you're struggling, here's the number, go get the support you need, and we have it available for you. We need to recognize that every layer here plays a role in almost all of the things that we're talking about. So there is a role, and everybody actually needs to have some ownership and accountability for that. And this is where the measurement is so important. So there are things that the organization can take ownership of, and I've listed some of them over here. I would say the biggest opportunity right now is in addressing the workflow and operational inefficiencies that folks are challenged by. That's what we saw with the patient hassle data, the friction points in the clinic. And that's what we hear all the time from those who are practicing, that we have got to stop and retool how we're doing this work so that we can keep doing this work. I think we skip a lot the 2 layers in the middle. And this to me is going to be the game changer here. How do we build stronger teams, and how do we grow leaders? Because at the end of the day, you may have a very senior level C-suite of folks, and that's great, and they're going to keep your kind of ship steady, but the real work is going to happen at this level. So training these folks, making sure they have the data and the support that they need to advance this work. And yes, it may be a negotiation if they need resources, and how do they get those resources so that they can, do their job and be the leader and advance with their team. And then I do, as you all know already, if we don't take the time to take care of ourselves first, we can't do any of this work. And giving ourselves kind of permission, not just permission, but insistence that we take that time to take care of ourselves first is absolutely critical for ourselves, but for our teams and for our organizations, and of course for our patients. Okay, so I think I've gotten to my last slide with my 1 minute left. Hopefully you all followed me through this. And there's a reminder in the chat about recording CME attendance. But hopefully all of you, are with me on this kind of 2 sides of the same coin, 2 different perspectives, but really the same set of solutions for addressing patient experience and really supporting clinician engagement. The importance of measurement, especially if we're going to hold all of those layers accountable, I don't think can be overstressed. And it's also really critical to use it so we can prioritize and not have kind of a shotgun-like approach to what we're doing. I think I've gotten it all in. So I'm going to stop. Thank you all for your time. And I hope that this was helpful. Thank you, Mira.
Thank you so much, Jessica. This was fantastic. And, we'll open it up for, even though we're at 1 o'clock, maybe for a question or two. And then, I have one that wanted to see if the work that you and Lisa Rodenstein did at the Brigham, looking at gender differences and burnout and fulfillment, was that specific to the Brigham, or do you see that translatable really across the country with your Press Ganey data?
Such a great question. Thank you for bringing that up. So I think some is very translatable across the country, and I would love to come back and talk to you about the gender differences because I really worry about them a lot. And then some was specific to our data, and I don't know if that's going to be something that we're going to see everywhere. But certainly in our data nationally, and also the work that we have been doing with the Brigham data, we are seeing the themes of the challenges that female physicians and female APPs have with being able to decompress, with feeling like they have the support and resources that they need to get the work done in the time that they have. We have lots of good data that show that female patients probably take more time, and female physicians often have more female patients. Female physicians often take more time. So there's a lot of drivers in this space. One of the things that we found in that paper was the lack of self-compassion and how female physicians score, worse on that than male physicians. And actually that explained a lot of the difference. And I think that that is true. And that is a societal challenge. And a lot's been written on that in other industries, the kind of how women tend to kind of set a really high bar and then beat themselves up. Plenty of men do this too, but it's more common, I think, in a lot of women, and certainly something we found in our data.
Dr. Fisher or anyone else with last moment questions? I know we're out of time. And again, thank you so much, Jessica, for coming down, even though you're not here in Concord, but hopefully we'll be able to bring you here soon to visit us in person.
Well, thank you so much for having me, and I would love to come visit.
Thank you, everyone.